just in case you have missed anything in terms of our RNE talks, we want to ensure everyone is comfortable in the use, know all the benefits of it, the side effects, when it should not be used. We welcome Dr. Roberto Garcia, who's going to speak a bit more on the RNEs.
Hi, good afternoon, everyone. Thank you very much, the Heart Stroke Foundation, for the invitation. I really feel very, very glad of being here with you. I'm greeting all of you from Guatemala. I'm a clinical cardiologist and also an internist in Guatemala, so a pleasure to be here with. Please tell me when you can see my screen. I think this is the most common phrase used during this pandemic. Please tell me if you can see the screen.
Yes, we're seeing your screen.
So, perfect, there we go. So this is my conflict disclaimer and my conflict of interests. And we know that heart failure has always been here. Is the oldest known case was an Egyptian dignitary in very, very early years before Christ. Then there was this Yellow Emperor's Classic and Journal of Medicine where they described heart failure as early as 2000 BC. The Romans and the Greeks also described heart failure, and it was Hippocrates who described congestion. And it was when the ear is held to the chest and one listens for sometimes, it may be heard inside like the boiling vinegar. So it was talking already about congestion, and it was talking about very, very early signs of pulmonary edema. In 1932, the President Franklin Delano Roosevelt, he was a sick patient with heart failure. And we started to see that he had gradual elevations in blood pressure when he started to see as a normal person for his age. The personal physician of Winston Churchill said that he looked tired and there was an evident deterioration, and he was having elevations of blood pressure that went from a range from 136 of a systolic blood pressure to 188 of systolic blood pressure. Eventually, he was admitted to the Bethesda Naval Hospital where he had dyspnea, diaphoresis, and abdominal distension. He had hypertensive heart disease, and also heart failure. He also used medication for that time that was digitalis and reduction in salt intake, and his blood pressure was 240 over 130. Eventually, he passed away due to a stroke in April 12, 1945. And when he died, the last recorded blood pressure that he had was 300 over 190. So that means that cardiovascular treatment at the time was very rudimental, and it was not the treatment that we needed. And we needed only to wait for the unavoidable. So we started to think, what is happening with heart failure? And we started to see that there was a very interesting thing that happened in the early 1940s and 60s, that this was a hemodynamic approach. This is something that it was only taught about and thought that it had only to do with having a lot of liquid held inside of the vascular system. Then in the 1980s, we started to see things according to another approach that this was very good and very well described by Dr. Elliott in the previous conference. And we saw that the neurohormonal approach was very interesting in order to tackle heart failure. This was the historical event of how heart failure treatment was being held. And we can see that before the hemodynamic approach, that mortality rate of 5 years was mainly in more or less 80%. When we took that leap to the neurohormonal therapy or approach, that 5-year mortality will reduce itself to 40%, which was half of what it was before. So the therapeutic objectives of a treatment for heart failure must be not only for the patient, but also for the health system. The patient should reduce mortality, the patient should reduce hospitalizations, which that should be translated into an improvement of quality of life and also safety profile. We need a patient that's taking a medication that has a low adverse event rate so that the patient feels comfortable in order to take it in order to feel safe. And for the health system, that medication must be cost efficient. It also must be in a directed patient program care. We see that this is what we were trying and we were having. Dr. Elliott beautifully presented in the earlier presentation. We used ACE inhibitors, beta blockers, the mineralocorticoid receptor agonist, and also the ARBs. We saw that the diuretics had no influence at all on reducing heart failure and reducing heart failure mortality, and also digitalis did not also reduce heart failure mortality and hospitalization. So this is something that we need to take from the hemodynamic approach into the neurohormonal approach. When we tried and we started to see heart failure, this is a record of the evolution of mortality in patients who lived in Denmark. We can see that the more elderly the patients were, the more probability of mortality they had according to the years. When the patients were older than 75 years of age, they were more prone to die of heart failure in contraposition to the people who were a lot were younger. So here we can see that the pathophysiology of heart failure, and I want you to see that this is the problem. The problem is the neurohormonal systemic overactivation, which gives us the symptoms that we go and we have. We cannot treat symptoms. If we only treat symptoms, we are not treating the very important thing that is happening. Now, when I talk with my patients about that, I'm telling them that this is when you have a leak on your roof. If you have a leak on your roof, you don't put a bowl inside of the room so that you can gather all the water that is leaking. That is not the solution. You go up to the roof and you fix it, because the problem is outside of the roof or inside of the roof when it's a plumbing problem. So you need to fix the problem where the problem radicates. And the problem in heart failure radicates in the neurohormonal overactivation of that system. We can see here that the heart is very important, and it's not only a fluid pump, it works as a paracrine, autocrine, nervous, immune system, and it has a very important hormonal response, and this is the natriuretic peptides. The natriuretic peptides effects are very important, and they have a very beneficial characteristics in the body. And this is something that had been traveling scientifics a long time. They were talking about, okay, you remember when we took the BNP or NT-proBNP as a prognosis factor, and we saw a patient with heart failure with NT-proBNP over 400, he or she has heart failure. If it was over 1,000, that was a very important thing to tell us that the prognosis of that patient was very bad. But we didn't see what that natriuretic peptides really were trying to say to us. The natriuretic peptides are, as Dr. Elliott Fortel told, they were trying to see that how to help their own body, their own mechanism, in order to try to survive the devastation of the cardiomyocytes. So this is something that you already saw and you already know. We can try to see here that the peptides generate a lot of beneficial effects, mainly the BNP and the AMP, which are the ones that mainly concern us when we're talking about the heart. And we can see here that the vasodilation, that diminishing of cardiac fibrosis, the diminishing of hypertrophy, and the elevation of natriuresis is a very important effect that the natriuretic peptides have on the heart in order to try to reduce what is happening in heart failure. We also know that neprilysin is the molecule in charge of destroying the NT-proBNP and turning it into inactive fragments. So it doesn't have the capacity of generating the beneficial effects that it wants in the body. This is a very important study shown by the Journal of American Heart Association, where we can see that when the patients had the highest quartile in neprilysin inhibition, we can try to see that those patients were the ones that had more admission rates in heart failure hospitalizations due to all cause, cardiovascular, and acute heart failure discompensations. We were trying to see that the higher the neprilysin was, the lower the event-free survival average was. So we can see here cardiovascular death and cardiovascular death or hospitalization. When the neprilysin level was higher than the median, this turned into a very low cumulative event-free survival rate. So the race started on. We tried to see if we can generate, if it was possible to generate a synthetic natriuretic peptide like neseritide, which didn't generate much benefit because this peptide was being destroyed by the neprilysin. Then we have the ularitide, which ularitide really didn't show any type of benefit. And at the end of the study, it showed us that even placebo was a little bit better than the ularitide at itself. So we were trying to reach and we were trying to see how to manage that natriuretic peptide system. We all know the very important problem that became before sacubitril/valsartan was developed, which was the omapratilat and omapratilat with the Overture trial, which the Overture trial needed to be stopped because this had a very important thing that didn't not only block the neprilysin, but it blocked the ACE inhibitor enzyme. So the thing is here that was that patients really debuted with a lot of very, very risky angioedema, and they died. So that was the problem, that the angioedema was one of the very important adverse events that generated this type of a dual blocking of also the ACE inhibitor enzyme and the neprilysin system. So this got the people thinking. They saw, okay, the same thing that happened with ACE inhibitors and ARBs, that we know that there are a lot of non-ACE pathways that can be used in order to turn angiotensin 1 into angiotensin 2. The same thing happened here in heart failure. So what they were trying to see was, okay, we can try to integrate and try to invent something that was not two molecules, but this is one molecule. It's a super molecular molecule that is called sacubitril valsartan. This is not a combination. This is one racemic salt. It's one simple compound, which generated a dual inhibition of the enzyme, of the ACE inhibitor enzyme, and also of the neprilysin. And we saw with the Paradigm trial, which was released in 2015, which was a groundbreaking trial, because not only was the only heart failure trial that was done against an active competitor, that still stands today. All of the other heart failure trials that we see had only used a placebo, and they are not using an active competitor comparison in order to try to see which medication could deliver the most benefits on the patients. We can see here that there was a very important reduction of 20% in the primary composite outcome of heart failure with death of cardiovascular disease and worsening of heart failure in hospitalization. There was also very important things that we can try to see, that death because of sudden death was also reduced in 20%. And this is something that generated a lot of noise in the time, because we were only trying a heart failure at that time with ACE inhibitors. People who were intolerant to ACE inhibitors were using ARBs, beta blockers, and some of them were using MRAs, because let's face it, in the Paradigm trial, only 50% of the people that were enrolled into that trial were using MRAs as a customary treatment. This is something that Dr. Elliott showed, and this is very interesting to see, because this is something that the Paradigm trial couldn't show at that time. The Paradigm trial was trying to show what happened in patients that were already diagnosed with heart failure. But this is something that we try, and I want you to look especially into the new onset heart failure, or the patient that are ACE IRB naive. Those patients are the ones that generate the most type of benefit when using sacubitril valsartan for the first time. This is something that is telling us that we don't need to be afraid of selecting and trying to pick that patient that hasn't have a diagnosis of heart failure, who's debuting that time with heart failure. We can start him with sacubitril valsartan, and the benefits are going to be bigger than the rest of the patients. These are some of the findings that we have from the PROOF trial, which was a comparison in how to see if the reduction of NT-proBNP correlates directly to the cardiac reverse remodeling. And we can try to see that there were very important parameters in reduction of heart failure. And we can see that the left ventricular ejection fraction rose in all of those groups. And we can try to see that all of the parameters that show us cardiac distension are reducing themselves, which is reverse cardiac remodeling. So the Pioneer trial, which was a trial that showed us also the use of sacubitril valsartan inside of the hospital, showed us that the benefit was even better if the patient started to use sacubitril valsartan when he or she was hospitalized. So this is something that we're trying to see right now. When we see the earlier we start sacubitril valsartan in those patients, and the most we spend not trying to see, we're going to give them an ACE inhibitor or an ARB. We're going to wait 2 or 3 weeks, 4 weeks, and they switch them to sacubitril valsartan. This is a practice that should be a little bit forgotten in time, because we can see here now that starting sacubitril valsartan in de novo patients and naive patients can be very beneficial. The reduction that we saw of death in patients and NT-proBNP was very important, and we can see here that when the NT-proBNP was lower than the median, we can see here that there was a time where the least amount of death of heart failure hospitalizations were shown in patients taking sacubitril/valsartan. So after all this, where does sacubitril/valsartan stand? This is a very important analysis that was done between all of the, we can say, RAS inhibitor class. The RAS inhibitor class comprehends ACE inhibitors, ARBs, and ARNIs. And when we try to see if we can have the ARNI, when we see the ARNI over here, and we compare ARNI to placebo, to the ACE inhibitor, or even the ARB itself, we can see that all of the times the statistical significance and the benefits that the patient is going to have is going to be bigger, not only in the primary composite of cardiovascular death, but also the adverse events of the patients were similar and were not statistically significant when we were talking about the benefits of sacubitril/valsartan within patients. The optimal therapy, as also Dr. Elliott showed us before, we can see here that we will have the most reduction of heart failure death when we try to use the combination of an ARNI plus a beta blocker plus an MRA. Recent studies have shown us that if we try to add an SGLT2 inhibitor to this therapy, we can try to reduce that even to 0.35. So we can reduce 65% of mortality rate when adding an SGLT2 inhibitor to this type of treatment. So we are now at the dawn of a new therapeutical age in heart failure, and also what Dr. Elliott showed us before. We can see here now that we have a very important decision to make in order to see where we try to put our patients and what are we trying to do with them. Right now, we have a very important concept that's being developed, and we have 5 objectives and 4 drugs. This is a very important new approach in heart failure when we see that there is no prioritization of order, but we can see here that the 5 objectives of treatment is the RAS system, natriuretic peptides, the central nervous system, the mineralocorticoid receptors, and the SGLT2 receptors in the kidney. This is what we need to do. This is what we need to do right now. Those are the 4 pillars that we need to have in treatment of heart failure, and there is no way that we need to go back into this. Why? Because we have seen, due to the results of the Paradigm, the Pioneer, Proof trial, all the trials that we have done with sacubitril/valsartan during this last 7 years that we have had that molecule in the market, we see now that the ACE inhibitors are being shown to be less effective in treating heart failure patients and reducing cardiovascular mortality. Why? Because we are leaving the natriuretic peptide system without any capability of fighting inside of a body that really, really needs them. So when we try to look at it, this is what we need to do right now. If you have a heart failure patient that is not in these 4 pillars, you need to really reevaluate what the patient really needs and what are the things that we need to do in order to make him have a better quality of life and in order to be with us a little bit longer. That's all I had to present to you today. I had a very limited amount of time, but I hope that the presentation was of your liking, and please, thank you very much. I'm very pleased to be here with you.
Thank you so much, Dr. Garcia. I think we're very knowledgeable now of the ARNIs, their benefits in heart failure, and the overall heart failure management. Thank you again for joining us.
No, thank you very much for the invite.
Yes, great.
Heart failure is a serious condition leading to inadequate perfusion of the inner organs. 2 neurohormonal systems, the renin-angiotensin-aldosterone system and the sympathetic nervous system, initially compensate by regulating water and sodium retention and inducing vasoconstriction. In the long term, however, they become detrimental. Currently available treatment options aim to inhibit these 2 systems. Another treatment approach focuses on the body's own cardioprotective mechanism, the natriuretic peptide system. Natriuretic peptides are released directly from the heart or the vessels to induce vessel dilation and thus unload the heart. As the natriuretic peptides are degraded by the enzyme neprilysin, the beneficial effects of the natriuretic peptide system are limited. Therefore, blocking neprilysin is a promising treatment approach in heart failure. However, neprilysin inhibition alone is not sufficient, as neprilysin also degrades the powerful vasoconstrictor angiotensin II and its precursor. The resulting increase in angiotensin levels outweighs the benefits of enhancing the natriuretic peptide system. Vimata, the first in-class angiotensin receptor neprilysin inhibitor, or ARNI, targets both the natriuretic peptide and renin-angiotensin-aldosterone systems. Vimata is a sodium salt complex consisting of the neprilysin inhibitor sacubitril and valsartan, an angiotensin II receptor antagonist. With its innovative multi-pathway approach, Vimata simultaneously enhances the beneficial effects of the natriuretic peptide system while inhibiting the detrimental effects of the renin-angiotensin-aldosterone system. In this way, Vimata restores neurohormonal balance and improves morbidity and mortality in heart failure patients with reduced ejection fraction.